Okay, our next section that we're going to go over is herpes simplex, perinatal infections. This is a DNA virus. This is a sexually transmitted disease typically associated with genital herpes. Most of these cases are herpes virus 2, although there can be genital herpes from herpes virus 1. This is a brochure from the CDC, Center for Disease Control. And what is the age of this young woman that's on here? Young women. And we're going to go over this a number of times before we're done, is that sexually transmitted diseases are twice as common among young people than older women. This looks at the estimated number of new cases of STDs, and I just want to put things in perspective. The most common is HPV, human papillomavirus. That's the most common viral. The second most common is trichomoniasis. This is parasitic. The third most common and the most common bacterial is chlamydia, and here is herpes. Herpes is the fourth in terms of prevalence. So we have HPV, trichomoniasis, chlamydia, and then herpes. And my suspicion is it's on the rise. Let's look at our case. A 21-year-old multipra was admitted at 39 weeks gestation in active labor at 6 centimeters dilated. Bag of waters is intact. She has a history of genital herpes prior to the pregnancy, so she has a previous history. Her last outbreak was 8 weeks ago, and she now complains of vaginal lesions. And when you examine her, on exam, she does have a localized, painful ulcerative lesion on her right vaginal wall. What is the most common cause of painful genital ulcers in the United States? Herpes. What's the most common cause of painless genital ulcers in the United States? And it is syphilis. A painful ulcer, you must think of herpes. Herpes is a sexually discriminatory disease. The prevalence is more in women than in men. It is asymptomatic more commonly in women than in men. And it is harder to diagnose in women than in men. It classically shows up as a blister, as a vesicle. And here you can see diffuse vesicles. Those vesicles will then break and they will form painful ulcers. So we start out with entry of the virus, which becomes a vesicle, which then becomes unroofed, which then becomes a painful, inflamed ulcer. You notice the female, many of the lesions are internal, and that makes it much harder to diagnose. In the male, they are external, easier to see. What is the mode of transmission? Respiratory droplets? No. Body fluids? No. Mucocutaneous contact. We're looking at epithelium on epithelium. This is not toilet seats. This is not using somebody else's towel. This is genital mucocutaneous contact. Now, when we look at vertical transmission, which is from mom to the baby, what is the most likely? It is not transplacental, as it has been with many of these other diseases, like toxoplasmosis CMV. The route of vertical transmission is at contact at delivery with a genital lesion. So if the mother has a genital ulcer and the fetus is delivered through it, that is the highest risk in terms of transmission. Residual effect of primary infection. Is it lifelong latency or is it lifelong immunity? And this is going to be lifelong latency similar to CMV. Unlike toxoplasmosis, unlike rubella, which are lifelong immunity. What happens is the virus gets through the skin, it makes its way to the dorsal root ganglia, that's where it sets up housekeeping. And it's there for life. And then at intervals, stimulated by whatever, loss of sleep, stress, or whatever, out it comes, and typically it will reappear in the same location, the same dermatome. This is an oral herpes, which typically is not associated with genital herpes. Now this picture shows a florid case of herpes. Do you think this is primary or is this recurrent? Look at the edema of the labia minora. Look at the diffuse nature of these lesions. It's not localized. This is most likely going to be a primary infection. It's going to have evidence of systemic involvement. You're going to have a fever. You're going to have probably inguinal adenopathy. This is a severe case of cervicitis from herpes. And this is what we're concerned with in terms of infecting the newborn. This baby is infected, and you can see around its mouth. This is herpes of the eye. And this baby's not doing well at all. Our big concern is that these babies can become septic and die. And this baby's going to die. Necrotizing herpes infection. How do we make the definitive diagnosis? You can't make the diagnosis by looking. It's a viral culture, which is going to be your best. Some time ago, I was on duty in the hospital, and a family practitioner called me and said, I have a patient who has a genital herpes infection. I think she needs a cesarean. She was in labor, and I went to see her. She had a previous history of herpes, she said, and she had a lesion. So I examined her. It was not an ulcerative lesion. It was not. And it was not painful. I said, I'm not convinced this is herpes. She says, I know it's herpes. I know it's herpes. How are we going to tell? Viral culture. How long will that take? That's going to take days. And here she is in labor. So what am I going to do? I did a cesarean because I could not take the chance. But you cannot exclude the diagnosis unless you have a viral culture. Now, the attack rate, this is the likelihood that the fetus and newborn will get infected. 50% with a primary infection, 5% with a recurrent. So much, much lower with a recurrent infection. But 50% is pretty high. And if the newborn gets it, what's the likelihood it's going to die? 50%. That's serious business. So if we have genital ulcers at the time of labor, management, cesarean, emergency cesarean. So I'm not convinced that this woman had herpes, but I could not take the chance because the attack rate is just unacceptable. What is the treatment? Traditionally, the treatment in pregnancy has been acyclovir. It has a track record of safety. It is an FDA category C, which means no confirmed harm in humans, but it's not as good as category B. Valacyclovir and famciclovir are newer antivirals. They are category B and probably are better because you need to give them less frequently. Valacyclovir is a prodrug of acyclovir, which gives you higher concentrations with a lower dose. On the exam, however, if you're given a choice, I would use acyclovir because it has a track record of safety. All right, let's take a patient who has a history of recurrent herpes. And she knows that she gets these recurrences about every 2 months. We know what her due date is, and we know that she's probably going to get an outbreak at about the time of her due date. We'd like to keep her from getting a cesarean. What are we going to do? We will give her prophylactic valacyclovir treatment. And this is to decrease the rate of transmission and the likelihood of requiring a cesarean. This is advertisement for valacyclovir. The trade name is Valtrex. When it's infecting him, it puts her at risk. Well, yeah, I guess it probably would. Make it simple. Let's treat it. This is a study on which this advertisement was based. This was a landmark study where they used valacyclovir, and they showed that there was a decrease in transmission of 75%. What they had was couples, one of who had herpes, the other didn't. We call that discordant couples. And the control group did not use any antiviral. The study group used valacyclovir. Now, I was surprised that the control group had only a 2.2% of transmission to a sexual partner. But what was significant was that the group that was using the valacyclovir had only a 0.5%, which is a 75% reduction. Is that significant? Yes, statistically it is. And it was published in the New England Journal of Medicine. 1 daily valacyclovir to reduce the risk of transmission of genital herpes. Now, how often are you going to have to take this? Basically, you're taking it all the time, because you're not curing the underlying disease, you're just decreasing the viral load. This is a peripheral smear, not a peripheral smear. This is a smear of the scraping of a herpes ulcer, and it is the traditional appearance of a multinucleated giant cell. Now, this is specific for herpes, but not very sensitive. In other words, you can have a false negative. If you don't see it, it doesn't mean the herpes isn't there. What percentage of women of reproductive age are herpes IgG positive? 50%. And yet, do you think 50% of women have recurrent herpes? No. And if there is any good news about herpes, genital herpes, it is that most people who get the disease and who develop antibodies do not get recurrent lesions. But once you've got it for the rest of your life. This summarizes what we've talked about with a number of these perinatal infections, and you can see how prevalent IgG antibodies are. Varicella, 90% of women will be varicella IgG positive. 85% of rubella IgG positive. Herpes, 50%. CMV, 50%. Toxoplasmosis, 40%. So very prevalent is the IgG antibodies. This is an oh my goodness slide, and it's really just a few points that I want to make. We're looking here at various clinical manifestations of congenital infections, rubella, CMV, herpes, toxo, and syphilis. And you can see there's a lot of clinical manifestations. And the main thing I want to point out is that with many of these diseases, they will have manifestations of these various clinical findings which go across the board. Meningoencephalitis, hepatosplenomegaly, jaundice, there's no particular predominance. But notice with petechiae, there's only one of these diseases that is 3+, and that is CMV. There is only one of the diseases that is 3+ for chorioretinitis, and that is toxo. There is only one which is 3+ for intracranial calcifications, and that is toxoplasmosis. So it's just to reiterate, if you see a newborn with petechiae, think CMV. If you see a newborn with chorioretinitis, think toxo. If you see a newborn with intracranial calcifications, think toxo. And that is the end of herpes simplex.